So, Dr. Feagan, is it true that Canada has mandated that all patients on both Remicade and Humira be switched, and what has been their experience over the past 2 to 3 years? You have a microphone right there.
So we started off with the blame Canada question.
Yeah. Well, I started with saying it's an international conference, right?
No, that isn't true. In fact, the penetration of biosimilars has been very low in Canada for the same reasons it's been low in the United States, is that, you know, pharmaceutical companies are very shrewd commercial organizations, and if a competitor comes in, they figure out ways to block entry to drugs.
Okay. Dr. Lee, should we be screening our patients from a cardiac standpoint for the use of TNFs, especially among our elderly?
I don't. I'm probably not smart enough to detect class 3 or 4. But in general, if they don't have a significant cardiac history, I'm not sending them for an echo or to a cardiologist. And so, well, it's a relative contraindication. My experience, just like with demyelinating disease, is if all of a sudden they develop some symptoms of heart failure, you withdraw the drug and they kind of regress. But I'm not screening people for heart failure.
And I think the concern there is we're worried with our TNFs, it's a contraindication if there's a newer class 3 or 4, right? And so if your patients are not presenting with any underlying congestive heart failure signs or symptoms, elderly, what age do you start and what kind of screen would you do? Would you do an echo on all these patients? Not necessarily. And so the answer, I agree, I wouldn't be screening our patients just for the fact that they're elderly.
I wouldn't even know how.
That's a whole separate issue. So there's a question of, is there any role for a short course of steroids to decrease symptoms quicker in someone who is newly diagnosed with moderate IBD while they were also initiated on infliximab and azathioprine? Dr. Wahbeh, we'll get the peds perspective first, and then we'll get the adults.
I think we've shown in the pediatric world that you could actually reduce symptoms and reduce the inflammatory burden and actually induce some degree of mucosal healing with nutritional therapies. And almost doesn't matter what nutritional therapy is being used. The idea is maybe limiting the antigenic stimulation to the gut, to the immune system of the gut, and it seems to pay off quite well in the short term. And obviously, it's a burden on patients to go through nutritional therapies. So I think when you look at optimization of biologic response, obviously albumin levels, malnutrition, as Dr. Shevitz showed in his slides, that makes a difference. And I think we invest quite well in the first few weeks when we treat pediatric patients with moderate severe Crohn's disease with enteral nutrition, and during that period of time, that's when we actually give them vaccines. All the vaccines that they're due to, we use additional vaccines, a 23-valent pneumococcal vaccine, considering zoster vaccine, and you can give it safely because you're not on immune suppression. So by the time it's week 3 or week 4, their nutrition is optimized, their albumins are starting to come up, they already feel better. That's the perfect time to do it, and we do it steroid-free.
Okay. Dr. Feagan, do we control? Oh, Dr. Lee, yeah.
I think there's a real-life logistical issue, too. It's not like you can get a biologic in 2 hours. So most of my patients end up with initial diagnosis on steroids. I'd be curious what Brian thinks, because I think for induction, if you hit them, I believe in combos, so I use AZA and a biologic, but if they're on triple, so steroids, AZA, biologic, I think that may be a more effective induction. I'm not talking about long-term, I don't keep them on steroids, but Brian's commit paper showed us, infliximab and steroids is about as good as infliximab and methotrexate at 1 year.
So I think, the adult situation, I think, is a little different, and, takeaway message is do what you need to do to get them into remission as quickly as possible. And if you compare across studies, something I don't advocate, but in this case I will, if you look, what did top-down show us? You could treat patients without steroids, okay? It clearly showed that. But if you look at the remission rates in top-down, these were naive patients with disease duration of 6 months on average. And then you look to the study Scott referred to, COMMIT, Those people had 10 years of disease rate, and the rates of remission were higher in commit than top down. And the difference was that both groups in commit received induction steroids on top of infliximab. So
it's triple therapy.
correct.
So can I ask, how do you balance, the whole notion of, driving the message time and again that adding steroids adds a risk of infection? We have a risk of mortality with steroid exposure in IBD.
Don't go beyond 8 to 12 weeks.
So, and what doses are you using? And if you're going towards a biologic, like Scott said, you're working on getting the biologic, are you using steroids for 2 weeks or 4 weeks? Are you using lower doses?
Still using
30, 40
good old
milligrams?
NCCDS up to 16 weeks,
No, I usually, let's say it takes you 2 to 4 weeks to get your biologic secured. I will tell them to start tapering once they've gotten first or second induction dose. And the goal is by 8 to 12 weeks, you're pretty much on physiologic doses or less.
So we're saying for induction of treatment for moderate or severe disease, we could induce with our corticosteroids, recognizing that really beyond doses of prednisone, beyond 40 or 60 milligrams, anything beyond that, stop. Don't go higher than that, 40 to 60 milligrams, but definitely start your tapering down appropriately, and then specifically after they've received at least their first, if not their second induction dose of their biologic that you've chosen. And at that point, that's where the role of combination therapy comes on as well. But Scott, any role for now this JAK inhibitor? So can we try that for the first few weeks, and then rather than steroids? I mean, we're talking about induction of treatment. What about a JAK for induction of treatment, and then transitioning them to a biologic or a thiopurine?
I don't think we know that. Certainly JAK seem to work quickly. I don't think you can get a JAK quickly.
I can get a JAK,
because again, insurance companies tier these things, and the JAKs at our institution are not quite as expensive as a biologic, but close. And so could you give someone a JAK? I would be afraid to give them AZA or methotrexate. Well, methotrexate not so much, but I'd be afraid to give someone a JAK, AZA, and a biologic all at once.
No, but what if you just give the JAK, give them a few weeks,
A
see
JAK
what
and a
happens?
biologic?
No, just the JAK, and then see what happens. Can you induce, and rather than giving steroids, just the JAK?
Oh, just use a JAK? Sure, you could.
I'm asking you, would you?
Sure.
Okay.
If you could get a JAK as first line or second line, and you want to give them another course of steroids, sure, you could give it. But I wouldn't just induce with it.
Okay.
Yeah, and I would want to maintain. I mean, again, most of these patients, when they got randomized to placebo, regressed.
So you would give it without steroids potentially, and then if they're doing well, maintain them on it.
Yes.
But if they're not doing well, any harm in us giving a JAK with a biologic? Brian? I'll get you off.
Well, we don't know, but I think from first principles that JAKs are broad-spectrum immunosuppressors. Certain biologics are broad-spectrum immunosuppressors, and I wouldn't combine two broad-spectrum immunosuppressors. So to me, chocolate and peanut butter here is probably TOFA plus Vedo.
Okay. So TOFA, Vedo, now they flare and not doing well.
On both?
Sure.
Can't do that.
Yeah,
Why
that doesn't
not?
happen.
I'm sure we've all had patients that flared
Don't do
on
that.
much worse. But then at that situation, would you potentially stop the TOFA, add some steroids, and then determine what needs to be done?
Sure.
Okay, maybe.
I think the dilemma that people have talked about, you give them TOFA, and maybe they get response but not remission, and I think most of us say, oh, well, you could add vedolizumab, but we're not too concerned about that. I think the bigger question is, let's say they go into remission.
And then which one do you
What
stop?
do you get rid of?
Yeah. So what do you get rid of? What would you get
You
rid of?
get rid of the broad-spectrum
Okay.
immunosuppressors.
So the TOFA, right? So,
And you can come back to it if you want to, right?
and that's the beauty with our small molecule agents, this risk for immunogenicity or developing antibodies. We're not worried about that with our small molecules. We're worried about that with our biological products. And so going on and off, using it as a broad spectrum to allow for induction of treatment and then getting them off of it. And then if they require it again, starting it back up, it seems like that might be a good option. Okay, so when there's a lot of questions that I'm still getting on drug level monitoring, and I would love Dr. Feagan's input on this. This question says, we've talked a lot about the TNFs for drug level testing, but what about drug level testing for vedolizumab, ustekinumab, and potentially future biologics?
Right, okay. So as general principles, is reactive drug monitoring a good thing? I'd agree with Adam, and I think he downplayed that actually. Spent a lot of time on proactive drug monitoring, which we know very little about. But having said that, generally it's good to have measurable drug at trough. And if you don't have measurable drug at trough, you need to increase the dose. And where the thing falls down a little bit is that it's quite a complicated business to figure out what therapeutic drug monitoring relates to in terms of anti-drug antibodies, because you have to walk it back to PK in patients who have clinical failure. And to do that, it requires you have to get a cohort of, in the case of infliximab in the Prometheus assay, it took us 5 major groups to collaborate globally, 1,500 samples to work that out. And that's the only assay where that has been worked out, that we know what the anti-drug antibody concentrations mean. And that has not been done for any of the other assays or any of the other drugs. So it's a problem. So there are commercial assays for Vedo, there are commercial assays for Usta, and I believe the assay manufacturers that they can measure those drugs. They can measure the drugs, it's the antibodies that's the problem. And one thing that was actually Adam put up was the results of the AFIF study of ustekinumab, which purported to show that the therapeutic target trough concentration for Usta was 5 micrograms per mil. That's absolutely incorrect. The paper actually has come out from the trials. It's 1 microgram per mil. And you can blame Canada on this one. You could really blame Canada on this one, because the reason they got 5-fold wrong answer was because that was subcutaneous dosing and they weren't at steady state. So at that paper in CGH, if you read it, don't read it, okay? It's wrong.
Coming from the Canadian, there you go.
So can I ask, same question I asked Adam before, therapeutic drug monitoring and the practicality of what to do for a patient flaring week 6. And that.
Yeah, so here's where the devil's in the details. You can talk about measuring drug levels during induction, but you recognize you're not at steady state.
Right.
And if you look at the variances of you taking a single level and predicting the future, you can't do that. That's why clinical pharmacologists say, okay, you can do your population-based PK where you just take a bunch of random samples and build a model, but if you want to accurately predict induction drug dosing, you have to take multiple samples. Mm-hmm. And so is this impossible in clinical medicine with all the technology, your fancy phone and things you can stick into it? Yeah, it probably is possible, but we have the technology to do this, but no one's actually done it.
So Scott and Anita, do you give your patient an escalated dose and check levels if they break through in the maintenance phase week 6? Or do you check level and wait week 6, or what do you do?
I mean, if they're flaring...
God, you know the answer. You're a cave guy, right?
Yes.
Give lots.
I give them
lots.
more. I mean, the honest answer is I'm not afraid of a biologic. I'll give them as much as I can. I'm not a big proactive TDM person. You know that. I'm not sure that we know what to do with that. But I would probably, if it's infliximab because I know it's free, I'd probably check a level and give them a bigger dose and almost out of curiosity see where they were. I don't de-escalate either. I mean, I get levels of 25, 40, and they're fine. I don't de-escalate either. So I would empirically, as Brian has said, I am a caveman. I just say you're flaring, more drug must be better.
And I think the difference there is reactive, proactive, all the rest is really trying to understand if your patient ever initially responded to the treatment, right? If they responded and are now losing a response, or if they initially, even by week 6, if they were initially doing well and now losing a response, maybe potentially in those patients the caveman approach may work for some. But it's the other side, which I say that is still difficult for us, which is it's not so much that they are losing a response, but perhaps they never really responded. And we're not just talking about clinical symptoms, but we're also talking about what if it's still that mild elevation in their CRP, or what if their CRP didn't mount, meaning that 15-20% of our populations, their CRP is normal and they could have severe disease. So in those ones, I would say it's a little bit more difficult. And in those patients, it's really trying to stratify and understand, are these primary non-responders to this class of biologics? And that's what we're trying to differentiate. It's still up for debate, reactive, proactive. That's why we had Adam present his data and information, but certainly something where empirically dose escalating, especially if insurance is not going to give you an issue or a problem, and if you could dose escalate and they initially were doing well and now losing a response, any harm? I don't know, right? I don't think so.
You know, the one thing I'll say about TDM too is, at least I think most of us want an endoscopic target, right? Treat to target is endoscopy these days. I don't think it's symptoms. I'm not sure if it's CRP or whatever. And
So we mean, by treat to target, we mean mucosal healing.
right, so we
Okay.
want mucosal
Deep remission.
healing. And all of the TDM, which is associations, is not, we don't know what the level of drug that will get us the best mucosal healing. And so a lot of times, I don't care what the drug level is. If they still have active disease, I'm going to dose escalate.
There's a few questions on, has anyone, and I'll be honest, I have not, but has anyone on our panel or even in our audience used the Prometheus mucosal healing test as a marker for active disease?
I have not.
It's not validated.
Correct.
It's amazing how diagnostic tests can get on the market
Right.
and cause untold harm, not being validated, and as opposed to drugs. It's remarkable.
Mm-hmm.
And I thought there was an abstract, I think, but not a full publication. I think that's where the background is. And what it is it's a gamish of, inflammatory cytokines and put together in an algorithm. But I have to say, I have not used it. I think, we're not at a stage where any test can be a good surrogate. I would say, including fecal calprotectin. I don't think that's a good surrogate for mucosal healing, outside of endoscopic exam and imaging.
So, Anita, you alluded to the treat-to-target mucosal healing as per STRIDE guidelines, and in UC, the guideline of reaching a Mayo 0.1 is a reasonable and attainable goal.
Mm-hmm.
I think the people on STRIDE then did something very probably bad in Crohn's disease. They said, well, you guys can't measure the SES-CD scores, so we're going to be practical about this and give you a target of absence of large ulcers. That makes common sense, right? The only problem being is what the clinical trials are now showing us, since we've moved to endoscopic endpoints 5 years ago in Crohn's disease, is that if you take patients who have failed a TNF blocker and you look at the success rates of our best new therapies, that all the things Scott talked about, it's single digits for mucosal healing. So it's a bridge too far in Crohn's disease.
So this whole treat to target approach and really mucosal healing, what Dr. Feagan's saying is, should we lower our targets, our goals in our Crohn's patients as opposed to the ulcerative colitis? Combination therapy in someone on ustekinib, Stelara. Yes, no, maybe? Why?
Well, coming back to the principles of combination therapy, what does it do? It prevents immunogenicity, it raises drug concentrations, and it probably hits multiple mechanisms, which is a good thing, and which is how we're going to get away from those single digits. It's going to be combination therapy. The next generation combination therapy is going to be akin to hepatitis C, HIV, where you use multiple targets. And that's the horizon. That's within the next 10 years. But so in the case of USTA, you don't have to give combo for immunogenicity. So if you've got a low-risk patient that you're starting USTA primary, yeah, monotherapy, it's fine. However, if you take the typical patients that we see who have failed 2 or 3 drugs, I'm giving combo with conventional immunosuppressive. I don't have a sonic study, but I'm generalizing the results of sonic to that situation.
Right, right. So remember, the risk for development of antibodies with ustekinib or Stelara is very low, 2 to 3%, if not lower, and as opposed to our TNFs, where this risk is 15, 20% risk, if not higher, right? And so we're not so much concerned about trying to reduce the risk for the patient developing antibodies. We're more concerned about perhaps some of these patients have really ongoing active disease and they've already burned through or failed other therapies, and now we're trying to optimize them and improve efficacy of our medication regimen for these patients. What about for vedolizumab or Entyvio? Combination therapy?
I do.
Okay.
More about, well.
What is the risk for immunogenicity with Entyvio?
It's similar
Excuse
to,
me, vedolizumab.
It's similar to all the TNFs. And for TNFs and Vedo, I'm usually using AZA for 6 months. And unlike Adam, I will put them on methotrexate long term. I don't trust patients. They don't always take their drugs on time. And this is, it's sort of a backstop to protect them. But I agree with Brian about Eusta is you got god-awful disease, you failed everything else, you're coming up to Eusta, I put them on dual. You got mild disease, middling disease, and you've maybe been on one biologic, I'd let them go on monotherapy, especially older patients, I'll let them go on monotherapy.
Yeah, I think the Vedo situation is a bit more nuanced. So if you're starting Vedo as primary therapy and the patient has strong beliefs about drugs, as they often do, then I'll accept the risk of a 10% sensitization risk because I've got other drugs in my back pocket. If you go to the other extreme, as we talked about Usta, somebody's failing everything and I'm going to Vedo, I'm using full dose immunosuppression with it. There's a lot of people that live in Middle Earth between those extremes, and there's where I think low-dose oral methotrexate, 12.5 milligrams once weekly, is a really, really good strategy. To prevent, there you're just using it to prevent sensitization.
Okay, so low-dose oral methotrexate, 12.5 milligrams weekly with folic acid, 1 milligram oral daily. We use that as a potential alternative for those who we're trying to avoid the thiopurine use, right? And so again, we're using it for combination therapy and indications where we're trying to avoid or are concerned about the adverse events associated with our thiopurines.
And can I actually ask Dr. Feagan, since he's here? This is a question that comes up, sadly, in my patient population, and I'm sure a lot of friends and adults I know with IBD ask, but can you drink, or how much can you drink if you are taking 12.5 milligrams orally once a week?
We're not
Same
talking about
method.
last night.
I think this experiment has been done in the U.S. population who are a little portly
Published?
and
or
drink a lot.
Are we talking about Scott?
In 100,000 patients treated with rheumatoid arthritis.
Right.
So yeah,
Tall.
it's excess, however you
Yeah.
define it.
Yeah. No binge drinking. We worry about if they're on higher doses of methotrexate for longer years or duration. We worry about hepatic fibrosis or steatosis. But at the dose we're giving, we're with no everyday full binge drinking, I think we're fine. Binge drinking more than 3 or 4 drinks a day for the male and 2 to 3 for females. Brian, can we use biosimilars, the drug and antibody assays we currently have available for biosimilars?
Okay, well, there's 2 schools of thought. The way your assays work, they're TNF capture assays. And so the target is plate-bound TNF. So conceivably, you can measure biosimilar drug concentrations with any assay because it's just a question of how much it's picking up on the plate versus the marker reagent. Anti-drug antibodies, here's where the 2 schools of thought are. Okay, so the antibodies are anti-idiotypic antibodies. And so again, that's the TNF binding site. So your anti-drug antibody assays should cross-react as well. And the other school of thought would be, yeah, but you've never measured any antibodies to any other regions in the antibody. So, yeah, to be determined.
Okay, so potentially we could use it at least for drug levels, right? But for antibody levels, I think to be determined, but certainly to use those same assays. And the take home there is just recognize what assay you're using. Is it a drug tolerant assay or not? And to really being able to understand if you're just looking for drug levels, it really doesn't matter much in regards to your antibody levels for right now, but more to come, certainly. Scott, if you develop a psoriasiform rash on an anti-TNF from your medicine cabinet, what next? Do we switch or do we try another TNF?
I think in this day and age, it's easy to switch. Even if half of the patients could do okay, I mean, you can always come back to a TNF, but I think most of the ones that have it so severe, I mean, it's terrible. I mean, their hands are sloughing off their feet, they can't walk. And they want it to be done, right? They don't want to go through another cycle of, oh, let's try the second TNF. Oh, it's getting worse. So mostly I switch.
What do you switch to?
Could be Vito, could be Eusta, could be Tofa.
Depends on insurance.
Yeah, sure, depending on insurance. Yeah. But I think you have a good argument against insurance. This is a class effect. I don't want to stay here, right? So because normally, at least in the Northwest, you got to fail 2 TNFs, then we'll let you move on. But I think you have enough to say, I don't want to stay in this class of drug, so I mostly switch. Tom?
The psoriform lesions that are associated with anti-TNF use, these sort of paradoxical skin reactions, are exquisitely sensitive to the P40IL-1223 mechanism. There's a nice German publication on that we got 4 or 5 years ago.
So Eusta.
Before Eusta was even approved. It's very successful.
Dr. Ullman is stating that for the paradoxical psoriasiform rash that is induced because of our TNFs, what we have with a nice German study is that if we use ustekinib for these patients, that's probably an appropriate next step because the induction of this initial paradoxical rash is actually induced by a mechanism that certainly ustekinib can control. And
Good.
let's be honest, ustekinib is used for psoriasis, and so another reason.
Because I don't read the German literature very much.
It was in gut.
Oh, God. I don't read very much, let me just say.
That's the British
That's
literature.
a whole different issue.
Even worse.
British literature.
So why do we need biosimilars?
Canadian to American drinking, and now we can rip on the Brits.
Yes.
We
That's
could always
low-hanging
rip on the
fruit.
Brits. No. So why biosimilars? Why do we need them?
Why?
This is a question. I'm
Why do we
biased,
need
but
them?
why should we have biosimilars?
Money. Somebody
There you
made
go.
it.
So it's
Somebody
a
created
question of why do we need biosimilars? I think it comes down to cost, right, guys? This is why we bring about, I'm not saying biosimilars are generics, but this is why we have our generics. We're trying to drive down costs. And so that's what ultimately all of this comes to with the initiation of biosimilars. We hope it's also access. Maybe if we have more availability with reduced costs of these therapies, maybe perhaps we could get less pushback from insurance companies. But here's a question saying, I'm still dealing with insurance companies where it says you must try an oral agent first. What do you do for that patient? So any suggestions? In Canada?
Well, an oral agent, okay, so I think there's something lurking behind that question, and it's the supposition that oral agents are necessarily safer and they should be tried first. That's not true. And you're going to see a lot about this in the next couple of years.
Yeah. So a safety profile, right? I mean, whether we're talking about our steroids or our thiopurines, they're not safer. We know that. We know that personally from what our patients are experiencing, and both short-term and long-term side effects of steroids in and of itself should be enough to remind you it's not safer just because it's oral. But there's more literature to come and more data and information to come. We're headed to lunch here, and we're a few minutes over. But before we do that, let's do our post-ARS questions just to make sure we have learned something from Scott Lee, Dr. Lee, and then we'll head out to lunch. Let's do some post-ARS.